Good morning, buenos días, good morning. Aquí reportándome Alexa Guzmán, intérprete español. Hello, hello. ¿Necesitan que hagamos alguna prueba? Do we need any sound check? Remember, you need to put me on a different channel. Okay, good. Okay.
J'ai tout, hein, c'est tout. Tu crois pas que je me suis brouillée?
in the sun. Hi, I hope you're all there. There's a lot of attendees. I must
Espero
thank
que estén aquí.
all the attendees
Espero que
for,
todos estén aquí.
I need to, can you close the translation?
No.
So we're just having a little problem with the Spanish translation that may not be simultaneous with me. But this is really exceptional. We have more than 2,200 registrants for this workshop or webinar that I think you will really like, because it's extremely important in the medical practice of any physician to be able to balance the female hormones well. And we'll see this in much details. So let me share you my screen. And I think it's that. Okay, good. So we have a Spanish translation. This will be the first time, but also the courses are now being translated into Spanish. So for those who speak Spanish and don't know much English, it's the occasion. Female hormone therapy in pre- and postmenopausal women. This is really what the core of hormone therapy. If you're able to balance well as a physician the female hormones, you'll go far in this practice of hormone therapy. It's very important too. I believe that you also somewhere help society, because if women feel better because they're well balanced with the hormone, they're in better health, they look better, many things will improve. We live still now in a world a little bit too much dominated by dominance, violence that is not typically the feature of the female hormones. And what will be very special in this webinar is that we're not only talking about giving female hormones to women in the postmenopause, once they had menopause, when there's a catastrophic decline in female hormones, but also much before, in adolescents, in young adults that may have a lack of female hormones, and also women in middle age, long before they have the menopause. So there are, in this model that I'm going to talk in a little overview, there are 4 sessions. And the first session is about diagnosis of female hormone therapy deficiencies, and the second session about female hormone treatment, and the third will be adjustments. And in the fourth, we'll have Dr. Armando Farmini from Austria, who will talk about providing female hormones to women who had breast cancer, and we'll also talk about the risk of breast cancer. And you will see, you will have a lot of valuable information. So let's go in the first, what's in the first session. I'll give you some clinical pearls that you already can take home. Everything that I say is usually based on review of the literature, and I go far. I have several students working for me to search literature. We go up to 40 years back in time. So you really have a good overview of what what is necessary to know about. But still, all this webinar and the webinars I give will always be predominantly oriented to practice, so that you are able to improve the health. Also, nutritionists can have a lot of information, because we'll talk about how the diet affects the female hormones and how it can improve the female hormones just by the diet, and also nutritional therapies. So let's first give an overview of what are the actions of female hormones. First, you have the estrogens. The estrogens, they have psychological actions where they stimulate the orthosympathetic central nervous system. That makes you give more energy and being more dynamic. And you see here that it provides a sort of excitement, fire within. And it also gives energy. And you have also joy, and you have also love that is given by those estrogens. And progesterone is an other hormone that has actually often antagonistic actions, not only psychological, but also physically. If the female hormones give energy, give excitement, the progesterone, and I'm talking about bioidentical progesterone, the same progesterone as we have in our body, women and men, that one, and not the synthetic derivatives. Some synthetic derivatives can, but not all of them, have this calming effect, calmness, You give a sort of coolness situation, relaxation. Woman looks like an angel if she has a lot of progesterone, and also it improves the sleep. You have a good sleep. And there's also a decrease in premenstrual syndrome. It actually nullifies most of the premenstrual syndromes, decreasing irritability, anxiety, and replacing it by calmness and good. I cannot read what is this. Yeah. Excuse me, I'm saying that I'm not sharing my screen. So let me see here. I'm sorry if you didn't have that. Okay, I think this is good, and voila. So here you have the slides that I'm showing about progesterone, and I'll show you the slide if you haven't seen it about estrogens, where you get all these different qualities with the estrogens. And there's also physical qualities that I see more in depth in the model on female hormone therapy, and especially the session 1. And so we won't go too much in details, but basically estrogens retain water, while progesterone stimulates the excretion of water. And I'm talking again of the bioidentical progesterone, which is actually better adapted for the body in most cases when you need a treatment. Now, those female hormones are also in balance with the male hormones. Yes, the male hormones. Women also need to have male hormones. They have them, they produce them. For testosterone, it's maybe 20 times a lower amount, but the other androgens are produced almost in the same quantity. At like there's 3 times less dihydrotestosterone, and there's even sometimes more androstenedione, and there's at least 66% of the DH sulfate of women have. So they have a lot of androgens, and they can suffer from that. And we have even a special model with 2 presentations of 2 hours on on the androgens in women. So they have to be in balance. So to make a woman feel good, it will not be only solved by giving the female hormones. You have a real balance between all the hormones, and it has to be adequate. None of those has to be too much. And so you have, for example, the estrogens, which are actually produced in very small amount, but they're so potent that they need to have big quantities of progesterone to balance them, like you see here. And the testosterone and the DHEA sulfate, etc., also have to be in sufficient amount for the female hormones actually to be well balanced, so that a woman really feels good in her skin and has a tonic body, and I would say not only a beautiful body, but I would say a beautiful temperament. Very important, the temperament. These female hormones give to women a femininity that actually we need more and more in this world. And if you don't balance those female hormones well, then a woman can be too irritable, too aggressive, or depressive. That's not what a woman is made for. She's made to feel good and to look good and be healthy. And you're able, as a physician, you're able to improve that. If you're a nutritionist, also, you can improve that in a very adequate way. So I will also talk about the cause of female hormone deficiency, and specifically the cause of female hormone deficiency long before the menopause. It's not only the extinction of the ovaries due to aging that gives female hormone deficiency, but there are many different factors that are frequently found in women that actually decline the hormones, so that they have a decrease in these hormones. So one of them is aging. And actually, the aging of the ovaries doesn't start at age 50 at the menopause. It starts long before, and one will have suffering because of those lack of female hormones. It starts at age 30 or 35 or even earlier. You see here, these are 2 premenopausal women. They still have menstruation, but they're lacking female hormones. How do I know that? Well, look, you see they're very pale and the eyes don't shine much. That's a lack of estrogens. And the hair is beginning to be flat here. And of course, a woman in the menopause, like this woman, has even more severe deficiencies. And her aging is not only due to a lack of female hormones, but basically much of it is especially the loss of feminine forms, and I would even say a feminine temperament to be excited by life. And here's a study in Australia where women between before menopause were examined, and they divided these women in several age categories. The 20 to 29, so those in the 20s, those in the 30s, and those in the 40s. And what they saw is that as age went on, from age 30 on, there was a significant decline in the two main female hormones, estradiol and progesterone. They fell slowly. So the aging and the lack of female hormones starts already at age 30 and not at age 50. And there were also other hormones that intervene in the ovaries, which are actually FSH, LH, inhibin, that also were declining. So the pituitary gland that secretes FSH and LH actually was getting lower secretion already at age 30. So afterwards it will increase because of this drastic decline of estrogens. That's a reaction. But basically it is a slow decline. And somebody's working, I think, on my computer, so I cannot advance anymore. So let me see. I'll do it this way then. Now, there's also very important aging of the ovaries, a premature aging of the ovaries due to previous pregnancies. And for example, here, you see this woman is pregnant. Everything's fine during the pregnancy. Good, everything's good. She has the delivery. She doesn't have postnatal depression, but she has one thing. And that thing is that she will be for life deficient in female hormones. And I have a little problem with the computer because I have probably people working on the computer. So I'm sorry if you have a lower screen. And you see, she has female hormone deficits. So before pregnancy, that's how a woman looks like. Beautiful, like every woman should look like and deserves to look like. But also, she has more color in her face and her eyes shine a lot. There's a lot of tears in the eyes. And actually, after pregnancy, we get this sort of aspect. Still beautiful woman, but basically her eyes don't shine so much. There's a thinner mucosa of the eyes, and globally she is paler in face, and the hair starts to get flatter. Those are signs of female hormone deficiency. And so after pregnancy, there's probably something like 10% less secretion of hormones than before the pregnancy. And here you see after pregnancy, women after pregnancy, they are so tired because maybe they don't sleep so well, but basically they're lacking female hormones. That's what you see. That this constant fatigue that they may have can just be a lack of estrogens. And so I will learn how to do it later on in the third session, how to treat women once they have had delivery, even if they are breastfeeding, how to give female hormones in a safe way so that actually they don't get this decline and they look as young as they looked before the pregnancy. Now, there are transient female hormone deficiency due to a low dose birth control pills. So many of those female birth control pills actually have now a too low content of estradiol. It's ethinyl estradiol, 20 micrograms is for most women, especially those who are physically active, it's too low. And so they get a sort of perimenopause, a decline in female hormones that is excessive already long before the menopause with the birth control pill. So we're going to look that into details in the session on it. And I want also to make your attention that it's not all about giving hormones and balancing the hormones. You also need to be sure that that women have a good diet because that can make a difference between 10 to 30% of her female hormones. So you can already improve female hormone function by a better diet. And so, for example, among the many examples I will give in session one, you can have female hormone deficiency due to a lack of protein intake. It's very important to have proteins. You have it gives energy and to produce more female hormones. Female hormones are made by fat, so it's not a direct building block for for making estrogens and progesterone. But basically, it's very important that women, if they want to have good female hormone function and good fertility, that they are able to eat protein. And usually it's the best form is animal protein. I know there are a lot of controversies, etc., but much of the controversy of the proteins intake and animal protein in women and men actually is due actually that it's cooked at a too high temperature and made toxic. And we'll see that even toxic eating with a lot of cooked fats, etc., declines the ovarian function. Here we see a group of vegetarian women that are not eating much protein or hardly any or no animal protein. And you see that actually what they have is that they have 32% decline in the serum estrogens. So globally, 30% less estrogens. So they will have smaller breasts if they all their life they had not eaten much animal protein nor animal protein. They generally don't develop breast fully to the Tanner stage 5. And you see that in those estrogens, there's 25% less of the very potent serum estradiol, and the estrone in blood, which is a weaker estrogen, is 44% decreased. So there's really a decrease in this, and we'll see in the course why. There's something to do also is that there's not enough production, but there's also a greater loss in the stools in those who eat a lot of fibers. And here you have okay. Here you have also a slide that is the start of a little chapter, a subchapter on how a lack of fat intake affects the female hormones. And you see these are fatty foods, egg yolk, you see also butter, you see liver, and the lack of animal fat gives that there's not enough of the very important building block of sex hormones, which is cholesterol. Actually, sex hormones is a modified cholesterol. And the fact that if you don't eat enough of these type of foods, there's a lack of estrogen production possible just because there's enough building blocks. And you see here a study on young girls, 8 to 10 years old, who had a high LDL cholesterol. So the pediatricians said, eat a low cholesterol diet, low fat diet in general. And after 7 years, they ate that. What is the result? Well, the result is that at age 15 to 17 years, like this young lady here, you see actually that in the follicular phase, the first phase of the cycle, there was 30% less total estradiol and 30% less serum estrone. So the major estrogens were 30% lower. And for progesterone in the luteal phase, second phase of the cycle, where you have most of the progesterone made, well, there was a more than 50% drop in the progesterone. So this gives also less fertility, and there was more testosterone actually. So basically, it's an imbalance that can also give more body hair growth in women to be on a low-fat diet. And you know also what? If you listen to some of my other presentations in all these training program, when people who eat low fat are much more irritable and easier depressed. So also the mood is affected by these lack of sex hormones. And you also see here is a slide that is before several slides where I'm talking about the fact that you should be avoid burnt foods, and we'll talk about several types of burnt, the trans fatty acids, and others, like for example here here you see the cyclic aromatic hydrocarbons. They're very toxic. They made when you barbecue your food, especially the meat. For example, you get polycyclic aromatic hydrocarbons, and in several studies, this has shown to in vitro studies on laboratory cultures of cells of the ovaries or on ovarian tissue, you see actually that it destroys primordial egg cells in mouse and rat ovaries. So it should do the same in humans. We're not better or worse neither than those animals, but basically we have the same structure. So we might really suppose that this also happened to us. So stop eating barbecue foods. It's not good for your ovaries. You damage them. And if you lose primordial oocytes, you'll get easier as a woman the menopause at an earlier age. And in the meanwhile, you'll have some deficiencies. And also here is female hormone deficiency due to coffee drinking. And we'll go over that. There will be also slides shown on how due to soft drinks also. So soft drinks and the sugar it contains not good also. And also due to a low zinc. So basically, we'll see also nutrients that are important, and we'll see also in the second session also more information on nutritional therapies, how they can improve the ovarian function. So you have here a summary, and that will be given. So you'll always get an overview in all the presentations I have. I try to that you have a sort of overview so that you know where all the factors that can help, and also especially the major factors that can help. So let's look now at the diagnosis of pre and postmenopausal female hormone deficiencies. And the diagnosis is based on a clinical syndrome of lack of female hormones, but also on lab tests. And there's actually another feature is that when you give a treatment, it has to work. It has to decrease those symptoms to be sure that you're treating the deficiency correctly. So let's look at some of the complaints. You see here that, and that's a basic idea that I will repeat over and over because it's so important, that on many aspects, estrogens and progesterone have opposite actions. So when they're deficient, there are also opposite consequences. And so, for example, the estrogens decrease the orthosympathetic nervous system. And so the person will get more tired and have a low mood. And that will be more or less constant the whole day. We'll show graphs about that. And when progesterone is lacking, you're lacking a stimulation of the parasympathetic nervous system, so the person will be more nervous and aggressive. And so you will have these two aspects that sometimes can alternate in the same person because that person is deficient in estrogens and deficient in progesterone. So you can get accumulation of both complaints, irritable and low mood, low energy. Here you have estrogens that we have seen, or we will see in the session 1, that physically there will be a water loss because there's no water retention anymore, or not a good one, and there will be a sort of tissue atrophy because of lack of estrogen, and women will have droopy breast physically, and they will have lack of menstruation, spasmodic dysmenorrhea, and so it's painful cramps, painful now, and then it releases, then again pain, and then again some rest for the pain, and the dry vagina. And actually what is characteristic for lack of estrogens physically in a woman who still has her menstruation is that it aggravates or appears during the menstruation, the problems most. And progesterone deficiency is the opposite. It will give a water retention, and there will be consequences of the water retention because of a lack of progesterone that is excretes a diuretic, and there will be tissue hypertrophy, and there will painfully swollen breast, and there will be heavy menstruation with a lot of bleeding. So the opposite, because you saw here that in estrogen there's poor no menstruation, and here there's heavy menstruation, and here there's droopy breast, and here the breast will swell up too much and will eventually also enlarge. And there will be even too much secretions actually. There's painful swollen abdomen also, constant dysmenorrhea in this place of spasmodic dysmenorrhea, and actually the excessive lubrication. So you will have opposite, and those symptoms will be much more found before the menstruation. So if a woman has both deficiency, she'll have in the menstruation problem and premenstrual, there will be more problems. But you see this opposite. And in order to balance well female hormones, you need as a physician to know well all these symptoms, because you will know what is then the solution. If it's estrogen deficiency, you'll have to give estrogens and progesterone always together. But if it's progesterone deficiency only, well, then you only give progesterone. So we have, of course, a lot of references that back up all these things. All these things is really very scientific, but still very practical. And you see here physical signs of estrogen deficiency that you can see, and that's a fundamental sign. Dry eyes. You see that the eyes don't shine more. They're a little shineless. You see? And so I always look in the eye. I ask the patient to look on the sides, and then I can look into the white of the eye, and it basically doesn't shine, doesn't reflect the light enough. That's estrogen deficiency. And often then the patient is also very pale. There's not enough blood in the skin of the face. Estrogen deficiency is the first thing to think of in a woman in the premenopause. And so you see here the stages of breast development in women. Okay, what this means is basically that if a woman in full adult age, she has outgrown the puberty, is still in one of these stages, she has too small breasts, and that's called micromastia. And that's actually the most frequent cause behind that is the lack of estrogen. And average optimal, and so it should be between 4 and 5 or 5 good, or that woman will have complaints of estrogen deficiency, including the constant fatigue in the background. And so basically for stage 1, there can also be a slight appearance of breast, and that's enough to have 5 to 14 picograms per ml or 20 to 50 picomoles per liter of estradiol. And when a woman, a young girl, is actually at that stage, she is already at 50% of her maximal pubertal growth. So there's 2 years, 2-3 years where a girl will grow very strongly, very fast, and a lot of centimeters per year. And well, she's already at half of that. Because it's the estrogens, the more estrogens a woman has, the more there's a fusion of the growth plate. So we know that is beginning to stop. So if you have a girl that wants to grow, and you need to make her grow, and she's already at that stage, you only have 50% less of the maximal pubertal growth. And what you can do is possibly block the estrogens by Arimidex for a year or two to make her gain some centimeters, maybe an inch or 2, but you'll have to do that because you're already getting late. It's better to have a girl who's small and needs to grow more at an earlier age. And so here you have the Tanner stages. All these Tanner stages are always above the 14 picograms, 50 picograms to get at that stage. So you see that actually a small increase of estrogens can only really give breast formation in a girl, because basically the average value of estradiol in a man is about 20 picograms per ml. So men should have small breast, actually, but because they have more testosterone that blocks a bit the action of estrogen, they don't get breast development then, unless they get much higher levels of estradiol. And then we'll see also the physical signs of progesterone deficiency. There's much more slides on the signs of estrogen deficiency, and we'll have also much more slides on progesterone deficiency. But basically, you need to look at the breast. If a woman has a normal breast size, but she's progesterone deficient, she will have painfully swollen breast at the moment before menstruation, in the premenstrual period. Painful at palpation also. If it hurts, a sign there's not enough progesterone for the amount of estrogen that person has. And if it's during many years that there is this estrogen predominance with not enough progesterone, the breast will start enlarging. Here you have painfully swollen breasts. They're a little reddish, they're a little inflamed. That shows that they're painfully swollen. And that happens, they get enlarged if you have years of untreated progesterone deficiency. And at certain time, there will be a drop of estrogens, and then the breast will become sagging. After a minute, there will be no pain anymore. They remain enlarged. You cannot shrink those breasts anymore. And they remain enlarged, but they're a little droopy. So you know that you're probably, for that breast, not anymore progesterone deficient, but you're already estrogen deficient because of the droopiness that there is. So you can have an idea of what happens with the hormone by looking at the breast. And female hormone deficiencies are linked to increased disease. We'll see a lot of different disease, cardiovascular disease, osteoporosis, and things like that. Here I'm showing a slide, what happens when there's estrogen deficiency, what type of diseases can come up easier. And one of those is rheumatoid arthritis. So women start declining in female hormones. Their ovaries get weaker already at age 30, slowly and progressively. And those lacks of female hormones can be associated with an increase of progressively of rheumatoid arthritis. You see here the stage, a beginning stage of rheumatoid arthritis, and then it goes worse in the arthritis extends or gets more aggressive with some lack of bone density also. And then there are really malformations appearing, severe rheumatoid arthritis, and then it can be internal rheumatoid arthritis. All these bones get fusion together, and you're really having, I say, a damage done to the hands and to the bones of the hands. And that is much more frequent when there's estrogen deficiency. You see, for example, rheumatoid arthritis itself is 2 to 4 times increased in women compared to men. They have it 2 to 4 times more. And women who have used oral contraceptive have 50% less, because the oral contraceptives have one advantage, is that they provide sufficient estrogens in most concentration to prevent rheumatoid arthritis. And maybe not the smaller pills, but at least those at 30 or 50 microgram of ethinyl estradiol. And so in middle-aged women, elderly women who have taken in the past, when they were still menstruating, oral contraceptives, 65% decrease of rheumatoid arthritis. So it looks like these estrogens and progesterone maybe also are protective against rheumatoid arthritis. And you see that even osteoarthritis, another form, so the aging form of damage to the joints, osteoarthritis or arthrosis in Europe, and in male mice who are very prone to it, estrogen administration decreases much the development of this osteoarthritis. So it works against rheumatoid arthritis and osteoarthritis. And then there's also effects of estrogen on progesterone. We have a series of slides on that. I'll show you one of those slides, is that estrogen or combined estrogen progesterone therapy in at least 3 studies here have shown that it decreased the life expectancy in postmenopausal women. So it's not only for quality of life, but also to live a longer life and probably healthier life, that you need to have female hormones in the menopause. And then what sort of lab tests? There are female hormone tests that you can do and that you should do. And the main 2 ones is estradiol and progesterone, because those are the 2 most important female hormones. However, there are other tests to do, and I'll show all the advantage of doing additional tests, how it helps you to evaluate more the intensity of female hormone deficiencies. And here we have, for example, that I provide that also in the slides, the optimal level for women. And here it is a Caucasian, it is Afro-American or an African. Usually those are the good values. However, in Asia, because of mostly of the food is not ethnical or racial, they are smaller and need less, and they are less developed because their food is poor in animal protein, so have less development of the ovaries, and they might need about 20% lower level, like 120 picograms per ml, for example. And in progesterone, it's 18 nanograms per ml would be a good value. However, it can be fluctuations, and you still will have to rely to balance well the treatment on the complaints and physical signs more. We'll see that a little later. And you see that actually progesterone is in huge amounts compared to estradiol, because this is in picograms per ml, 150, and this in picograms per ml is 18,000 picograms per ml. But they are at those concentrations both in balance with each other. And so if you want to put it picomoles, I gave you the formula here to do it. It's 550 picomoles per liter and 58 nanomoles per liter. So whatever your lab test shows, you'll be able to follow the presentation well and know what to do. And so here is another test that is very valuable to do, and explain why, and some of the explanation is here, is that SHBG, sex hormone binding globulin, transports in blood estrogens and male hormones, testosterone, dihydrotestosterone. And when it's excessively high, and that's a value that is almost at the upper limit or above, the upper limit of the references, what we see is that this high level keeps all the hormones as attached in the blood longer, so that it doesn't go in the cells as easily. So that can also block part of the estrogen action, because it less bioavailable estrogens will go into target cells when SHBG, sex hormone binding globulin, is high. And then when it's excessively low, and that's a low value that is below the average level within the reference range, and up to 0, well, then the estrogens are not attached well to the sex hormone binding globulin, and the sex hormone binding, and that makes that the estrogens go too quickly in the target cells. And what happens then when the blood goes to an organ like the liver, the first part of the liver will get all the estrogens, and much less will come in the second part of the liver. So basically, it gives an imbalance in supply of organs with this. So you really need to have this HBG at a good value that is around the 65 nanomoles per liter. And then we'll show also information on FSH. Depending on when you ask, FSH is the hormone of pineal gland that stimulates the secretion of estrogen by the ovaries. LH is a hormone of pineal gland that stimulates the secretion of progesterone by the ovaries. So basically what we see is that FSH changes throughout the cycle. Around ovulation, there's more, not as much as the LH peak, but there's more. And you need to, in order to be able to interpret the lab test, you need to know some of this information, what is normal and what might be abnormal. So basically, in the follicular phase, the level doesn't go at 10 or above. Generally, it's below, and the level is around the 6. So if you do in the follicular phase, if you do it in the later phase, like for example, ovulatory phase, it can go to 15, 20. So that's maybe not the right moment to check the LH. And I generally check FSH and all the hormones in the second phase of the cycle, around the 21st day of the menstrual cycle, about 1 week before menstruation. And there, what we see there, the FSH is at its lowest level, actually. It's between 2 and 4 in a healthy woman. So if it's higher, suspect already a beginning of what is called the perimenopause. In perimenopause, FSH increase. So I'll explain that in detail, so don't worry about that. If a woman gets menopausal, the FSH is above 30, and that's a real pathognomic sign, a lab sign of menopause. However, it can still change, so you still need to make a check in the next 6 months. And so we'll see all this. And so what are the most important female hormone tests? I'm giving you an overview, is that in a woman in the premenopause, you need as a minimum to ask FSH, estradiol, sex hormone binding progesterone. Why not LH rather than FSH? Well, FSH is more frequently pathological when there's a problem. So basically, it gives more information. FSH is when it starts increasing its level, the woman is then in the perimenopause. 8 years before the menopause, she starts in that period. So it gives you already a sign that there's a weakening of the ovaries, and we're also getting a depletion of the egg cells. So if there's a fertility desire of a woman, you know that she has to speed up to get a baby before she gets then too deficient in FSH, in ovarian function, and that is marked by high FSH. In the postmenopause, the same tests are valuable, but the progesterone not valuable because it's always low actually in a woman. And estradiol is also low, but it can be very low or moderately low. So it's really worth to check that. And so you'll get all the explanation why and for and other that you need. Now, you would ask, when should I check the female hormones in a patient, a female patient? What is the best day to check? We'll tell that. I already said that in the when there's a menstrual cycle, it's about 7 days before menstruation. If the menstrual cycle is longer, it is still 7 days before the menstruation. You need to take that into account and count the days. So what are deficient female hormone levels? Well, in the labs, you can detect an ovarian deficiency by several tests. And here's an overview. If the FSH gets higher, more than 10 or equal to 10, you start being the perimenopause, especially if this is in the second phase of the cycle. If it's at 30 or above, it's postmenopause normally. Also, a low estradiol can give that, and a low estradiol in the second phase of the cycle where you get some peak values, it's between 0 to 100 picograms ml. That is insufficient for any woman, and that's between 0 to 440 picomoles per liter. In the menopause, it's 0 to 75 picograms per milliliter. And SHBG also, if it's above 75 nanomoles per liter, like I showed, it's not a perfect situation. If it's below, you have a low SHBG, it's 0 to 55 nanomoles per liter is too low. So you really need to be about the 65 here. So all these values help us. So too high or too low SHBG can give a female hormone deficiency, an estrogen deficiency. Low progesterone is then also, and low progesterone, if the luteal phase is between 0 to 11 nanograms per milliliter, that's still, much of these values are within the reference range. You don't have an optimal progesterone. It's too low. You don't have to have a deficiency when you have a total absence of a hormone. Just a lower level within the reference range can also give symptoms of deficiency and complaints and suffering. Menopause is 0 to 1.5 nanograms per milliliter of progesterone. That's too low. It's so basically in the menopause, there's still some progesterone made, but by the adrenal function, by the adrenal glands. And if the adrenal glands don't work well, then you will have almost undetectable levels of progesterone, and that's not good for health. So we'll also put a focus on the fact that you can have estrogen deficiencies within or below the reference range, and we'll show some of those studies. So what I want to show here is that there's, in the blood test, in the follicular phase, for example, a lower limit and an upper limit. In the follicular phase, serum estradiol levels are in general, not during 2 days, but the other days, they are actually lower than in the luteal phase. And 95% of premenopausal women have normally values between the lower and upper limit of the reference range. And in menopause, these limits are lower, but that's not healthy, because we will see that you have at all these levels of women in the postmenopause actually disease, an increased risk of disease. And So here, for example, between 0 and 35 picograms per ml, there's an increase in ischemic heart disease. And between 0 and 49, there's an increase in ischemic heart disease too in another study. So basically being at a level here where still women who are young can be, is not healthy. They have a higher risk of cardiac diseases. And in studies on primates, on monkeys, it's shown that if menopausal primates are put on receiving estrogens, and they have atherosclerotic coronary arteries, they don't open if the level is not high enough. It has to be 60 or above. So all these levels are not healthy, and we can expect that this is also the case for female hormone, for women here, for human women, as for monkeys in the third study. And you see that there's an increased risk of cardiovascular diseases, a study in 1997 that showed that at levels between 0 and 96 picograms per ml. So all the levels in the follicular phase, if they're constantly for the whole cycle like this, it's too low. You have an increased risk of cardiovascular disease. So where's the upper limit of postmenopausal? It's full in all those pathological areas, at least of those 3 last studies. So this is the reason, because of this association, that we need not to put women at sky high levels, but we need to put them at levels high enough to avoid these diseases. So they have to be above those levels, at least in the luteal phase, for a woman to keep a safe heart. And this is the same for bones and other studies that we'll see, so that you really know the literature about it. So these are levels that would be good, would be levels at 97 or higher picograms per ml, or 355 picomoles per liter. And progesterone deficiency, you also have the same sort of reasoning with studies, is that you need to be at optimal levels, and we'll see those studies. What about the salivary test? Well, for progesterone at least, it doesn't seem to be good. Salivary test is the third option. You have blood, you have 24-hour urines where you can check estrogens, and salivary test third option, because in the saliva there's a concentration, concentrates and excretes progesterone and estrogen. So it's those tests are not so helpful. We'll talk about that in detail. 24-hour or night dry urine test will give information about that, and we'll see also patient cases, so that you get used to how to treat female hormone deficiency. And then in the second session, we'll see, which also reviews the scientific literature, how to treat women in the pre and post menopause. And what is interesting is always to start with the food. That doesn't mean it replaces the hormones, but the diet, the first consultation, you already can give the useful tips for the diet, so that there will already be a 10 to 30% improvement of the female hormone levels by a better diet. So what is the good diet? Well, basically, we'll talk about that there must be more proteins eaten and things like that. But I wanted to show you how to make female hormone therapy safer by improving a good metabolism of the estrogens. So here's a study in 191 healthy premenopausal women, and the higher the fruit consumption they had, the higher the urinary protective 2-hydroxyestrone excretions were. That's a metabolite, 2-hydroxyestrone, that is considered as a safe metabolite, and that is protective against breast cancer. On the other hand, the 16 alpha hydroxyestrone is considered as negative, as adverse, that it could promote breast cancer. And so by fruit consumption, increasing fruit consumption, you have actually a better ratio between the protective 2-hydroxyestrone and the more dangerous 16-hydroxyestrone. And it was also shown in this study that what type of fruit is better to improve these ratios. Well, basically, eating citrus fruits and bananas seem to be helpful. and then fruits of the same family. And so, and bananas had particularly also were those who increased the ratio between urinary 2 and 16-hydroxystrone ratio. I know there are some hesitation about bananas because they seem to be full of pesticides. There's too much pesticides used, and they've transformed these bananas, etc. And it's maybe not a fruit, a seasonal fruit that is eaten in many areas of the world. So it's mostly people who are originally from a region where there are bananas that may digest them better. But anyway, it's interesting to show that this is much better. You will not have that by eating a snack, a sugar snack with grains that are full of trans fatty acids and then not cooked at the right in the right way. So nutritional therapies, which nutritionals can increase the serum estrogens? I'll show you one. But there are several, and there's also nutritional therapies that can make that you avoid having too much estrogen predominance. So it's really interesting to have these data. Let's look at one of the treatments that can increase estrogen levels in a very significant way. And that one is actually boron. This is a study where there's women on a low magnesium diet or an adequate magnesium diet. They are in the postmenopause. And what we see is that if they receive 3 milligrams of day of boron, they're not receiving female hormones. They only receive boron for 4 months. And just for you to know, boron is a metal actually that is found in diets high in fruits and vegetables. So if you eat a lot of fruits and vegetables, you probably have sufficient boron. So those high fruit diets are not only good to have a good metabolization of estrogens, but basically they also help to have boron, which increases estrogen levels. And so a conventional diet that supplies boron with fruits is 0.25 milligrams, so a quarter of a milligram. So here we're giving actually 12 times more. And it markedly increased the serum beta estradiol and also testosterone. And it's even more marked in women on a low magnesium diet. And it also markedly decreases urinary excretion of magnesium. So there's less magnesium loss thanks to probably the fact there's more estrogens due to the boron intake. Interesting is that magnesium is one of the ways to reduce estrogen predominance. Women have breast tenderness who are irritable in the premenstrual syndrome, and when magnesium can calm that by decreasing estrogens. So if you have a low magnesium diet, you have more estrogens that can be made probably with boron because of the absence of magnesium. If there's more magnesium, it's lesser of effect. But it's interesting to know that it may be very significant as an effect. So we'll see a lot. You will see just nutritional therapies for patients who do not respond to estrogen. You can give them high estrogen. This doesn't seem to work. Guess what? What is behind that? Cobalt deficiency. And so I will talk what the doses is that is good for to give. So there really is several situations that can be helped already with nutritional therapies. And here is also the nutritional therapies, a chapter quite abundantly, I will talk about how to decrease excessive serum estrogen levels with nutritional therapies. And so here you see that an information about the magnesium also that calms down excessive estrogens, but also in postmenopausal women, which is not so good. So you really need, when you give magnesium to postmenopausal women, also to give the female hormones. And what I propose, I always give doses. So, it's like, for example, magnesium citrate, 200 to 600 milligrams of elemental magnesium. Elemental is real magnesium. Magnesium citrate will be, of course, heavier and a higher load. But that gives you the idea, if you want to correct magnesium deficiency and get good magnesium, is 200 to 600 milligrams per day. So now let's go to the treatment of female hormones. And I'm talking also about premenopausal women with still menstrual cycles. Even if the menstrual cycle is regular, they might be deficient in female hormones. We saw already on the diagnosis what to do. And then in postmenopause. So before I will talk about the specifics, I will talk about why is bioidentical hormone, because there's really a difference in efficacy between bioidentical hormones and non-bioidentical. So first, you can have natural bioidentical hormones, that is like estradiol, that is found in the human body and produced by the human body. But then you can also have natural estrogens that are non-bioidentical for humans, that are in plants, like the phytoestrogens, genistein and cumistrol, for example. They look a bit similar, but they're not totally similar, and they will be able to stimulate some of the receptors, but not all, and they will also block receptors. So it's not the best way of treating by only giving plant estrogens. If you don't have any other treatment to give to a patient than phytoestrogen, well, then maybe it's okay. But it won't be the same efficacy as giving bioidentical human hormones, and maybe even not the same safety. And you see here that actually placebo users had benign proliferative breast disease. So you have cysts in the breast actually in those who don't receive with time over the years in women, in this group at least. And then there were women who received estrogens and progesterone, and what you saw is that it increased. But there was none bioidentical hormones, because if you have the same sort of study with transdermal estradiol, bioidentical estradiol, and micronized progesterone, you have actually a decrease in benign breast disease. So also interesting is to note the birth control pill is not so harmless. This is ethinyl estradiol. It phases vascular lesions. There's one of the women who worked in the research team of Pincus, Dr. Pincus, who I think received a Nobel Prize for his discovery of and use and application of the birth control pill. And one of those said she changed her mind about these oral contraceptives, because the ethinyl estradiol thickens the intima of arteries and veins in animals and humans. So you get a sort of premature atherosclerosis. And it also increases serum triglycerides. It decreases the VLDL that are linked also to more cardiovascular disease. It also increases the blood pressure, because the arteries get thicker in their wall, and it actually gets more rigid. Yeah, so the blood pressure goes up then. The arteries are not so flexible anymore. That woman who wrote the book, The Bitter Pill, said also that there's a sort of inflammation of the arterial wall with the birth control pill. There are also diastolic blood pressure is up, the blood pressure in general. There's also an increase in blood viscosity with increased thrombocyte aggregation. And there's also a decrease in angiotensin 3 that actually prevents thrombosis, or helps to prevent thrombosis. So basically, not so good to give ethinyl estradiol during 20 years, for example. If you do it for 3 months, no problem. Maybe 1, 2, or 3 years, not too much problem, but basically think not 10 or 20 years birth control pill. And so the use of bioidentical hormones also increases the risk of getting genotoxic estrobias. This is a study where you see 2-hydroxyestrone, that's protective estrogen, and then you have 16-hydroxyestrone that is actually considered as more breast cancer promoting or able to change genes. And what we see actually is that compared to oral, you see the oral increases very much. If you give an oral estrogen, it metabolizes into 2-hydroxyestrone and also to the not so interesting 16-hydroxyestrone. And what happens is that if you give transdermal estradiol, you have much less metabolites. You have much less 2-hydroxyestrone, but even much more or less, 75% decrease of the 16-hydroxyestrone. So you're improving the ratio between the protective 2-hydroxyestrone and 16-hydroxyestrone. And what about estrogen administration? What type of estrogen given? Well, there's good information on that. So I'll show you some of the basic lines. Is that there are 3 main female hormones in women: estradiol, estrone and estriol. Estriol is more important during the pregnancy. Estradiol is the most potent one, the most efficient one. And estrone is more weakly, and there's some hesitation that it may possibly promote breast cancer. So this is the most potent, and this is sometimes useful morally vaginally for topical use, but it does not absorb well, so locally it stays long. You can take it orally, that is a way of helping, but it doesn't replace estradiol. So if you give female hormones, you at least have to give estradiol and possibly also estriol. So what is the best route of administration of estrogen? Well, the transdermal actually. And so we'll see pharmacy compounded transdermal estrogen preparations, and then we'll see also pharmaceutical firm compounded. So pharmaceutical firm that have a brand of transdermal estrogens. And so here, for example, you have transdermal estradiol made by compounding pharmacy, and they can be estradiol alone or biased. That is estriol plus estradiol. Now, they usually give much more estriol and not enough, generally, estradiol. So I prefer that the ratio is not 80% estriol and 20% estradiol. But if you do that, is to give 50% estriol and 50% estradiol, because many of those women I saw on biased were just deficient in female hormones because they did not have enough estradiol. And so that does also, you have to take into account that transdermal estriol does not absorb well to the skin. It's better absorption with estradiol. Triest, estriol, estradiol, estrone, it makes some sense to give that because that's how the body is. But there's some hesitation about giving estrone, so I wouldn't recommend giving a triest. And so we'll get a lot of information, but we'll go over it. If you can, it's better to privilege transdermal estrogen. That is better than oral estrogens. You saw one of the information that it's not only about bioidentical and non-bioidentical, it's also about the route of administration. It's safer, and I will give good information for that, safer to give transdermal estradiol than oral. Now, firms can compound transdermal, so we'll see which are maybe good. And then I'll give also information about oral estrogen preparation, because in some case you need to give that. A woman is dement, for you're getting dement, it's sometimes easier to give oral forms. And what are the good ones, if you can talk of good ones, is not the best route, but basically you can have safer ones. Oral estradiol is good. Oral estradiol valerate is also a choice that can have good results. But oral conjugated estrogens is really a third choice in those types of oral estrogens. And this is, of course, for treatment in the menopause or before the menopause, but this does not have a contraceptive effect to give that. Transdermal estrogen, we'll see about the daily doses. It has to be adapted to a woman, so you need to have some more profound information than I can give here now. So transdermal estrogens, we'll see where, how, and when to apply them, on which place of the body it absorbs better, how you apply them, thin layer or thick layer. I can already say put a thin layer and spread over a large surface, but not all surfaces are equal. And then I want to stress this, that some women, even if you give them female hormones, they seem not to improve on the vagina. The vagina can still remain too dry, so it hurts when there are sexual relationships. In that case, you need to add the first 6 months of a treatment in a woman, vaginal estriol. And sometimes it has to be persistently through, but some women, once it's improved enough, they can get out of it and just have a systemic treatment. And so the estriol that I propose is for vaginal dryness that does not disappear with systemic transdermal estriol. And there really I prefer estriol. And you have estriol vaginal tablets, or you have vaginal creams. And I'll get, you know what? It's often better to give vaginal cream. It looks more difficult, okay, but it's because most of the pain in sexual relationships due to dryness of the vagina is actually at the beginning of the opening of the vagina. And so it's with a vaginal cream, you can apply it there easily, while the oval goes a little too far. So you have less efficacy with the vaginal tablets for vaginal dryness. So adding estriol, we'll see with several slides why it might be interesting of giving estriol. But I basically have as a principle that I give already so many different treatments that I add estriol when there's still some vaginal dryness or dry eyes that remains dry mucosa, because estriol is very good for the mucosa. Progesterone treatment, micronized progesterone is really the first treatment I think of giving to a woman. And you know what? It works better to give it vaginally than orally. There's less sleep-inducing effects when you have it. So there's like 25% more absorption. So female hormone treatment of premenopausal women with menstrual cycles. So women at age 30, 35, 40, 45 may have regular cycles or maybe not regular cycles, but they may have a female hormone deficiency, and how to give the hormones. And so basically there are two types of hormones you can give in the premenopause. It's not contraceptive to do that. Estradiol gel or progesterone capsules. And estradiol is usually given from the 5th to the 25th day of the menstrual cycle, when you have to supplement a woman like that, after pregnancy, for example. After pregnancy and the breastfeeding is over, this is the type of days, these are the days that you need to give it. So the first day of the menstrual cycle is the first day of menstruation, and then you start counting. And on the 5th day, start with estradiol on the arms. And progesterone is then capsules, is given then in the second half of the cycle. So estradiol is given the whole cycle, and then the progesterone is from the 15th, 25th day of the cycle. So only in the second half of the cycle in most cases. There are some exceptions, and I'll tell you when, and we'll see this is in details. And so basically in the postmenopause, it's estradiol is given from the 1st to the 25th day of the month, to make it simple. And you give at the same time the progesterone, same time, same days, in the evening the progesterone, morning the estradiol. And that makes that there will, if the balance is correct, the doses are given, there will not be any menstruation. And if a woman takes a birth control pill, it cannot be balanced. She can be missing progesterone, she can be missing estradiol. So I explain how to correct that by adding to the birth control pill. And I have some better birth control pills to give. There's one or two that will be better. They don't affect the other hormones as too much. And also I'll tell you what the dose is given and when to give in this. Also, when women who have a progesterone intrauterine device, they usually are lacking estrogens. So they're tired, they have droopy breasts, they don't feel so good. So basically, that sort of treatment, intrauterine device, often has to be supplemented with estradiol and a little progesterone bioidentical, and that helps, and that remains contraceptive. As for the birth control pill, it will remain contraceptive if you keep the birth control pill, because what blocks fertility, is what blocks ovulation, and that's the progesterone in the birth control pill and intrauterine device with progesterone. Now, female hormones in postmenopause, they have a treatment. There's a treatment where you don't give menstruation, the one actually I explained. And then you have special cases where women are very sensitive to estrogens, and that is typically obese women. In the postmenopause, where it's better to give smaller doses of estrogens, because they can already have a lot of estrogens, even though they're menopausal, because the male hormones convert in the fat tissue, which they have a lot, into estrogens. And they also tend to have some tend really to have a lot of estrogen receptor levels. Those women have very large breasts, very large pelvis, very an accentuation of female characteristics. And you see here, so this woman, you start at low doses, and then women who have been very long estrogen deprived, you have to be more careful. Their body's in atrophy, and you don't need to to explode everything. So you basically go slowly and increase the dose. And women have not been treated since very long, like this woman. They have atrophic tissues and atherosclerosis. So there's possibly of intolerance of to estrogens, and so you start with low dose, and then you see if you can increase. Postmenopause with menstruation, there's some treatments where you can give menstruation. I'll explain how to do that, and then how to adjust the treatments. And one of the things is that some women who are very active physically, but they're active 3 times a week, very intensive. And then they get menstruation next day because they actually consumed all their estrogens by the heavy exercise or too much estrogens. Well, in that case, you need to add the female hormones the day of exercise, before or after the exercise. So you keep the values constant and there won't be any menstruation. I'll explain you how menstruation come up and how you can recognize what the problem is, and how, so you know the solution then. Female hormone treatment and the follow-up, very important to know, it's mainly on clinical signs and symptoms. The lab tests are not adequate. They can show gross abnormalities, much too much or much too low, but in between levels, that is really with clinical signs and symptoms. You need to do a lab test plus very good clinical screening and be able to ask the questions. So there's a balance between estrogen and then progesterone and androgens. And so you need to be able to get that good balance. Then I will talk about something more forefront. Is there a birth control pill? Is there a bioidentical hormone alternative? There is. I'll explain it, but not now because we don't have time and we need to show some other things. Also, I'll show slides on what female hormone treatment does on disease and lifespan. And then there's a whole list of placebo-controlled trials with bioidentical female hormones. Actually, most of the studies that are placebo-controlled trials with female hormones are with bioidentical female hormones. So basically, you're really backed up by a lot of studies. There are 263 placebo-controlled trials in women with estradiol only. It's not estrone or estrel. There are some for estrone and estrel, but less, but mostly with estradiol. There are 176 placebo-controlled trials with estradiol alone and 87 with estradiol and progesterone. And actually, we're constantly reviewing the literature, so there will be more placebo-controlled trials that will be shown up soon on in the module, because in the module you receive the handout, all the lectures. If you want this lecture, you have to subscribe for the module or for the session, and that will those scientific references will be constantly updated, and there's an update that's going to come within 2 months. So for the placebo-controlled trials of female hormones, and for all the other placebo-controlled trials of other hormones. So there will be patient cases, and then we go to the female hormone therapy adjustments, and that's really interesting because that part helps you to correct the balance between female hormones. And you have to know several things very well to be able to adjust. And there are 7 estrogen deficiency signs you need to know, and 7 estrogen excess signs and symptoms, or progesterone deficiency signs and symptoms. They're usually the same. And if you know that, with that, you will already be able to balance the hormones in most women who have female hormone problem. So let's look at some complaints that trigger your mind that woman needs more estrogen. Permanent fatigue is one of them. I'll show slides on that in HRT treated women. And the next model actually will be on fatigue, and then you get all the studies that are important on female hormones and fatigue. And so you need to increase the dose when you have that menstrual depression. I'll show you slides, and I'll show you when you have to adapt the female hormones, because it's not all the same. There are some moments in the cycle you might have to give estrogen and others not. And it's not the same for any complaint that you see. Premenstrual depression in women who are already taking female hormones. So actually, this session will be on women you're giving female hormones, but something goes wrong. and what to do. So you get the answers. So you have premenstrual depression. You need to increase the estrogen dose. Migraine and headaches in HRT women need to increase the dose when you have that if it happens at a certain moment of the cycle. Because it may be also, if you have migraine and headache coming up in the cycle, that you need to increase the progesterone. So to see the difference, that will be explained. Here, for example, in menstrual migraine, how is it caused? Well, basically, when there's a migraine, there's a low brain blood flow. And then there's low catecholamines and low catechoestrogen, because female hormones can stimulate catecholamines, but it can also convert to catechoestrogen. So they work as neurotransmitters that are stimulating. So the lack of blood in the brain plus a lack of neurotransmitters that make you stimulation can give migraines during menstruation. And usually if it is due to lack of estrogens, it's only during the menstruation that they come up. And if that is the case, you give the estradiol from a small dose. You don't need much, from the 1st to the 4th day of the menstrual cycle. And that can be already enough. So the woman probably already has here, in this case, estradiol from the 25th to 25th day of the cycle and progesterone 15th, 25th. But you add there, and this one also from the 1st to the 4th day, a smaller dose of estradiol. So here are some studies showing that estradiol improves migraine. And then there are a lot of other psychological complaints that trigger your mind. The patient needs more estrogen. Here we're going to look at some of the physical signs and complaints that can come up that should incite you to adapt the dose and increase the estrogens. Flat hair or hair loss on the upper scalp. Droopy breast in HR-treated women, you need to increase the dose. And you don't need to do surgery, plastic surgery. You need to increase estrogens because you will improve all the other signs and symptoms of lack of estrogens. Too much plastic surgery replaces actually hormone treatments, but not always in the best way because it does not improve the rest of the body as female hormones can do. Amenorrhea, lack of menstruation or hypomenorrhea must make you think there might be more need for more estrogen. So let's look at that in more details. You see, this is what happens. Estrogens stimulate the proliferation of the endometrium, the mucosa of the uterus. And then it becomes normal menstruation, but that sort of aspect that it should have. Now, if that is which you have adequate estrogen, if you do not have enough estrogens, what happens is this: you have very few mucosa formed because there's not enough estrogens to make more. And then you have more drop loss. So not really, it's hypomenorrhea. It's a lack of menstruation. If that happens, almost sure there's a lack of estrogens. Of course, if a woman has an intrauterine device with progesterone, the situation is different. She still can have no bleeding, but that's not, and will not change if you add female hormones because it's too much progesterone in the region of the uterus to permit mucosa formation. But that's a typical problem that I also will explain how to solve that. And also here, if the cycles are irregular or short or too long, that all is often linked to lack of estrogens. And again, I will explain what to do. But don't forget that if ever you give estrogens, you generally always have to give progesterone. If you can give progesterone alone, but you cannot give estrogen alone without adding progesterone. So keep that in mind. It's very important if you want to make things safe and balanced. And then we have here spasmodic dysmenorrhea during menstruation. And that is cramps and very hard, very painful. And then you have periods of nothing, and then it starts again. That's typically due to low estrogens. There's another dysmenorrhea that is due to lack of progesterone. This one is really hurts very strong, insufficient estrogen levels. And then what you do is you need to add, if it's during the menstruation, from the 1st to the 4th day of the menstruation, some small dose of estradiol. Small dose is sufficient. And then if it is so, you often also have other signs and symptoms that say, I also need to increase the estrogens from the 5th to the 25th day of the cycle. But on its own, from the first to the fourth day can be already enough. Dyspareunia, that means painful sexual intercourse, that is generally due to a lack of estrogen, but not all the time. You can have dyspareunia due to endometriosis or inflammatory states. And so I will also discuss about the other forms of dyspareunia. And recurrent vaginal infection, you often need more estrogens also. So here, for example, this is a study where women had bacterial vaginosis, and the vagina tablets were given with a little estriol and some lactobacillus acidophilus to restore the flora in 4 days, only 4 days, 6 days of those vaginal tablets, and it was enough in a placebo-controlled trial to cure the bacterial vaginosis within 2 or 4 weeks. So really, really helpful to have more estrogens locally there, and to also add some good bacteria. And to show how it works is that estriol, when you give it vaginally, it actually increased the vaginal pH from 6.7 to here it's 5.2. It's more than 10 times more acid then. In acidity, you kill all the bad bacteria. Only Lactobacillus acidophilus can survive that. The bacilli of Dirtline are actually Lactobacilli acidophili. Your recurrent urinary infections also often a sign that there's need more for estrogens in general, and vaginal estriol locally eventually. Also pelvic organ prolapse, so we'll show that with images and pictures, how to recognize it also. So body hair overgrowth, hirsutism will show also what to do, how to handle, and how to add transdermal estradiol. We'll also see how to add progesterone also. We'll see that in supplementary details to what we saw in the second course, because this is the third course. And then there are psychological complaints of progesterone deficiency that make you, that the woman needs more progesterone, premenstrual syndrome with irritability, anxiety, nervousness, also migraines, but then not during menstruation, but before menstruation, premenstrual migraines and headaches, that they usually are due to a lack of progesterone. So you should add progesterone, but you also have other signs that indicate you need it. And then you have also this, you see this premenstrual migraine, insufficient progesterone, you add progesterone, and when you add it, you can add it from the 50 to 100 milligrams per day of progesterone from the 18th to the 26th day of the menstrual cycle, if only progesterone is necessary. But if the one was already on therapy, you just added those above from the 15th to 25th day of the cycle, because you're giving the estrogens from the 5th to 25th day of the cycle. So that's, we'll explain that in details. And also, don't forget that you have a special question and answer session with a select number of patients if you subscribe to the model on female hormone therapy. So that will be very interesting to ask the question, because they're very interesting questions are asked by participants. Constant dysmenorrhea, that's constantly pain in the belly before menstruation, lack of progesterone, breast cysts also, but not only lack of progesterone. So you see that women with benign breast disease actually have lower progesterone-estradiol ratio. They don't have the good balance. And you are able to change that. Yes, you are sitting there and looking at this video. So the imbalance makes that there's more water retention in the breast and more disordered and excessive proliferation of epithelial cells of the milk glands. And so here are also studies showing that high estradiol levels and low progesterone levels give more breast cysts and fibrocystic breast disease. So basically, when you have that suspected imbalance, that you can correct. And we'll also explain how to get totally rid of the breast cysts, even in recluse disease. It's not only progesterone. So basically, you'll really get the information you want to have. You see all these studies showing that also progesterone gives improvement of breast cysts. It's interesting. Ovarian cyst, a bit same sort of problem. Here you see an ovarian cyst. This is the right ovary, and an ovarian cyst on it. Of course, that hurts when it swells up like that. And you are able as a physician to correct that well. Polycystic ovarian syndrome, that's a more extensive syndrome than just ovarian cyst. They have usually excessive body hair growth. So we'll show and we'll explain here some of the references. We'll explain what to do. And endometriosis, that you really need to be able to correct that because it's so dramatically impairs the life of a woman. And it's, I don't say it's so easy, but you really have the information on to correct that very efficiently, that maybe not an operation is not necessary. But don't wait till an operation becomes absolutely essential because you have waited too long. Excessive blood loss, probably more progesterone too. So we'll explain that. But there are also some types of situations where there's just too much bleeding because the blood is too fluid. So you need also to be able to correct that. How to add progesterone will be explained. And then we'll have special cases, a whole series. For example, female pattern hair loss, how to solve that. You see here to treat the cause, how to treat the female hormones with transdermal estradiol, oral progesterone. You really need to be able to, this is typical female pattern baldness that responds very well to the female hormones. But often they also need thyroid therapy because it makes the hair grow better. And to have a good food, meaning enough proteins. We saw the importance of proteins for estradiol, and also to avoid whole grain bread. I'm not going to say why, because everything is explained in the model. It explains something, requires several slides to really understand the mechanism. And there's also scalp here. You can put topical estrogen, progesterone, and melatonin oil 2 times a week. You have the formulas in my Reversing Physical Aging book on the head and hair. You have all the information. You have also the information in the Reversing Physical Aging model. And so you see small breast in young women, you need to increase the dose also, and we'll show how to do it. You don't need to do a breast prosthesis in a young woman. You just need to give the female hormone she's lacking, and she'll be better on many other aspects. Female subfertility, how to solve that. And here's some of the information. But the thing is that you have to give progesterone, estrogen, progesterone, like you give to a woman in premenopause, but you don't start the 15th day, you start the 18th day to 25th day with all progesterone. Transdermal estradiol will then, by giving the transdermal, you increase the estradiol peak that is around the 13th day of the menstrual cycle. And then there's a better LH peak, better ovulation. Also, thyroid therapy can be important. Adrenal hormone therapy can be important if there's deficiencies in that, because you need to do the test for that. And growth hormone can also help for female subfertility. So you really get a lot of information. And also the food. Again, more proteins and avoid whole grain bread. Then you have here pregnancy, what to do in pregnancy, what to do for postnatal depression. So simple, so efficient, and so good and so healthy. Breastfeeding, when there's breastfeeding, what type of treatment you can give, or can you give it? So we'll discuss this a bit. But I can tell you already that I gave it to my wife after a 2 pregnancy, and it worked wonderful. But you may not directly give it after delivery. So I explain how to do it, when to do it, and what to be cautious of. Then woman with premature ovarian failure. Also, we'll show how to treat that. And now there are special medical conditions where that can aggravate with estrogen therapy. So we'll see how to do it. Usually it's giving a lower dose of estrogen and a higher dose of progesterone, but it's not only that. So you'll need to have the specifics, and you'll get that. Here, one of the example is varicose veins. There you really have to give bioidentical hormones, and you need to give transdermal estradiol and no oral estradiol when there's varicose veins, and a vaginal progesterone rather than an oral progesterone. I'll explain you why in the session. Avoid oral estrogen and avoid estrogen excess. So you generally give a lower dose of estrogens in this case and many other cases where the estrogen therapy can aggravate the situation. And you need also testosterone. So you may not avoid giving testosterone to one with varicose veins, of course, in balance with female hormones. Then women with gallbladder problem, with cardiopathy, myocardial infarction, angina pectoris. Obese women also, what you do, we'll get in a little bit more details here. And then this is a longer section on how to treat difficult to treat premenstrual syndrome. You have solutions. And there are, I count 12 different types of premenstrual syndrome, and some women have 3 or 4 types together. So you need to be able to first know what could possibly give a premenstrual syndrome and what are the differences between the different medical premenstrual syndromes. And so basically, this is the end of the third session. Of course, a lot of slides I didn't see. We were just showing a fraction of the slides as a teaser, but also ready to give you information to show that there are solutions for almost any type of female hormone treatment that don't have to go down to surgery. And surgery is not a solution in many cases. Balancing the hormones is a solution, is the solution probably in most cases. So let's look also about estrogen and progesterone therapies for women with breast cancer, but the lecture will be given by Dr. Amanda Farmini, who has a good experience. And I'll give you some information, is that coffee, for example, intake can increase breast cancer risk. You see that 5 cups a day of coffee can increase the breast cancer risk in obese women, not necessarily in slim women. And if you drink 5 cups of more of coffee a day compared to less than 2 cups, 2 times it doubles the breast cancer risk. It stimulates the proliferation of epithelial cells in the breast. That has been shown in my studies. My studies have confirmed this carcinogenic effect of coffee drinking. Intermittent fasting can decrease breast cancer risk. So at least in mice, this has been shown. Mice were given, mice had spontaneously memory tumors. And when they were fed ad libitum, 77% of the mice got a memory tumor development, developed breast tumors. If they were chronically calorie restricted, they had a low-calorie diet, only 44%. So low-calorie diet helps. Don't overload your intestines. But intermittent fasting, which is eating what they want sometimes, and interrupted by often 2 days on 7 where they didn't eat, or 4th day or 3rd day where they didn't have food, they just had water, almost no tumor development. So intermittent fasting gave actually incredibly more than 20 times decrease and more than 25 times decrease in breast tumor development. And so there's several information you should know. They also treat key guidelines for female hormone therapy to decrease the risk of breast cancer is for female hormone therapy is to use the bioidentical ones. That's safer. There is a non-bioidentical progesterone that is safe also that I'll talk to you about, and that decreases the breast cancer risk. Transdermal route of administration for estradiol, that's really important. And then the third is to cycle. That means that you have a period of time when you give hormones, you stop. You don't give it the whole month through. You stop you give it 25 days a month, for example, and then you stop 5 days. That's important. That all decreases the breast cancer risk. And so using estrogen and progesterone can decrease the breast cancer risk. And this is a study with dedogestrone, that's a synthetic derivative, and estradiol was given. And those women, compared to women that didn't take female hormones, had 24% less breast cancer risk. And mostly the effect is due to dedogestrone, which is almost an identical progesterone, but not totally. So it's still synthetic still. And it slightly decreases the incidence of other gynecological cancers like ovarian cancer, uterine cancer, or cervical cancer. Use of other types of HRT that were not so good. Using estrogens before breast cancer, if you use it before, it decreased the breast cancer aggressiveness. Like, for example, you have smaller tumors, node negative usually, and grade 1, which is the lowest grade, meaning that it's much safer. You have less malignant cancer that's formed in a woman who had took female hormones before getting breast cancer. And there's also less risk of dying then because they took breast cancer. They took female hormone before breast cancer. And there are many other reassuring studies. Dr. Armani finally will go over many of them. He will talk about also the genotypes. If you have BCRA or know exactly the initials well, but women are predisposed to breast cancer because of their genes. It's safe to give them female hormone. But of course, you need to be a little careful. You get lower dose estrogens, more progesterone, and maybe other hormones that are protective. Also, taking estrogens before breast cancer decreases breast cancer mortality. And here is a Kaplan-Meier plot curve, and for breast cancer survivor, and the ones who didn't use didn't use female hormones before breast cancer had high mortality, and those who had current use of estrogen or estrogen progesterone had much less mortality when they were currently using, and at the moment they were diagnosis of breast cancer. So basically, you see here also same sort of information years since diagnosis. It's really long-term use is better than short-term current use to have better survival after breast cancer. And then what happens when you give estrogens after breast cancer? It can decrease breast cancer recurrence. Here's a study that shows you that you have breast cancer recurrence is decreased when you give progesterone alone, but if you give continuous estrogen and progesterone, you have 76% or 33%, but it's more efficient in women who have had breast cancer and estrogen and receptor positive breast cancer, meaning that you can give it to estrogen positive breast cancer patients. It's even more better in those patients. Using estrogens also decrease breast cancer mortality once they have breast cancer. And so the late stage where this is an early stage, at least when it was given, it can decrease up to 82% less risk of dying when you give estrogen after breast cancer in the one with early stage breast cancer, not too differentiated. Testosterone therapy also is protective. I'll give you one of those studies. Testosterone implants were put around the tumor. No, that's another study. The study I'm showing here is women who get testosterone implants with or without female hormones, because in the States they may give only testosterone as an implant, at least 6 months to 10 years. They had about 40% less risk of breast cancer, of invasive breast cancer. And it actually, the mechanism is that testosterone blocks proliferation of epithelial cells of the breast, makes also quicker that these cells die off, and it inhibits the estrogen receptor alpha and breast cancer growth in vitro. So interesting studies. So basically, I'm finished here because you'll get all the details much better explained probably than I can now in this overview seminar. But I hope you have already learned some essentials that we absolutely need to treat our women well. It's better for family life, for society life. I think we need more femininity in our society, woman power, not just the male moguls who think they know always better. We need to have the 50% women on power in families and in society. So save the date because I'm giving on next Thursday at 7 p.m. Brussels time a webinar for the A4M USA. It's actually, I'm explaining a lot of things, but I'm explaining the workshop I will have with them on the A4M USA on the February 20th. I can tell you it's an interesting workshop. We'll talk about hormones and immunocompetence and longevity. And there will be aspects also on chronic fatigue, how to treat chronic fatigue with hormone and nutritional therapies. There will be a session how to treat the sleep better with hormone and nutritional therapies. There will be also a session how to decrease inflammation by improving the diet. Very good studies by an overview again of last 40 years of studies that are there. It's mostly meta-analysis. And we'll also have special studies how to treat infection and with hormone therapies and so on. So there's really interesting. We'll have a possibility of seeing patient cases, and if you want to be examined also through internet, it's very safe. You won't be humiliated or whatever. You will be very happy to get you. You can also be a candidate patient, so we can do something very direct. So I really would propose you to go there. It's really exciting, and I like the AFRM because they're really doing a good job of promotion in the United States, and I think there's a lot of valuable information in all the lectures that they present. Here we see, so we have these on 24th, there will be a live question and answer session. That's for those who are in the models. So it's more select group, but you really have access to your answers to your questions. And then the March 2nd, I'll give a free webinar on the importance of nutritional therapies in all the things like infection, inflammation, reversing aging. So it will be parts that I'm showing all this evidence-based hormone training program where I have all those models. It will be parts, specifically the parts on nutritional therapies will be explained, so that you can, if you're a nutritionist, you can only do that. And that's really worthwhile. So again, a very interesting seminar. There will also be on March 17 online conference with A4M Dubai. That's really interesting. I'm not sure about the topic yet, so I cannot tell you. And there will also be an online workshop, the March 27, also translated into Spanish, like this workshop, with Bio Nuriso Mexico, a pharmacy that works there. It's very active in hormone therapy in Mexico. I think it's the most active one in the whole Mexico. And so basically, March 2nd, don't forget this nutritional training program. This is a free webinar that explains it. So you always get, clinical pearls. I like to give you a lot of information. There's so much thing that you can help your patients. And then again, a little word on evidence-based hormone therapy training program. If you really want to make it and be good and be able to balance and help your patients well, this is really fruitful for your practice. Even for your own, it's also practice because you learn how to do it. And there's a lot of information that is well structured. If you find it too much, you can skip a lot of slides because you say this is for later. But you will have all the information, because I think it's good to have all the possible information you need to really structure your mind, so you know how to treat a person with priority in your mind, what is more important and less important. So really get that information. Contact this email for more information, or if you want to subscribe, office@hertoghe.eu. And I want to make a special thanks for Dr. Jennifer Del Valle, that does the Spanish translation of the first model that she already did. That's really a great job. And it was people like her, we can probably extend more to the Spanish world. So I'm really grateful, Jennifer, that you're doing that work. I think you're really important, and what you do will attract more people in this formation. So this e-learning program, really go office@hertoghe.eu. Also the books, for those who don't know, there's a hormone handbook, and I'll have the questions after. I'm going to have the question. I know there's a lot of list of questions. It's more than 100. It doesn't go higher than the 100 for the moment. So wait for this. The hormone handbook, which gives all the basic information you need for the hormones. Really interesting to do that. The testosterone therapy for real gentlemen is my latest book, has everything you want to know on testosterone, even on how to treat prostate cancer patients with testosterone, how to treat prostate hypertrophy and things like that, excess estradiol, etc. Reversing physical aging, where you get all the formulas that you need to reverse aging with hormone and nutritional therapies. And then the Atlas of Endocrinology, where you see the physical signs of 20 hormone deficiencies and 19 hormone excesses. Really, really useful. A lot of pictures, more than 700, that help you to make your treatments. Also for general public, books like Hormone Solution, Passion, Sex, and Long Life, where you get the information you need to know about oxytocin. I like oxytocin. I think I took a lot of oxytocin because I smile more today. So maybe that's the oxytocin. And then the patient hormone handbook, which is some 10 hormone therapies and also nutritional therapies that you have, that is easy for people who have less money and want to have at least the essentials. And then I want to thank our partners, and our partners is so many that I cannot sound. There's BioSil, there's Preventage, and they were so active in Russia. Really like these people. They're really doing a great job. The Saham in Malaysia, the pharmacy compounding lab here, Sweet Treat, the Access Lab, Laboratory Reni, Pharmanor, Laboratories CopMed, 4000 Apotheke, Labofar, University Compounding Pharmacy, great partners all the time, Vital Plus, LIMS also lab, Tertia, Yvonne Murpuri, that does so good work for us, the VIP, Pharmacia, Laboratoria, that are active in Greece. So very, very good, and also in the pharmacy in Argentina, Saham, Your Health, Pharmanor. So really, we are really having good people here helping us. And if you want more information, this is the website, Hertoghe Medical School, office at hertoghe.eu. So I thank you for your attention. And then the questions. And they seem that there's a lot. You have the question and answer. So I'll first look at that. We can't see your screen, so that's arranged now. Good afternoon, good evening. That for such an incredible opportunity. Unfortunately, I have 5 hours difference. I'm afraid I will not be able to attend. Okay. What age is it best to start testing? That's a question from Dr. Grace Siaya. At what age is it best to start testing the estrogen and progesterone hormones? Is it in pre-adolescence, adolescence, maybe? It depends. I would say from age 30 on, all women should be tested for estrogen and progesterone. But if there are disturbances like premenstrual syndrome or a lack of menstruation before, even at puberty, when normally there should be menstruation, you should check the levels. And in that case, if there's, for instance, very early a problem, you should also ask prolactin. For prolactin is high, can suppress ovarian function. Traduction français, we don't have any translation in French yet. If there's a candidate, would be good. Harlan Bailey, would a decrease in essential fatty acids show up as sex hormone deficiencies? Would the replenishment of these substances of omega-6 and omega-3 return sex hormones to adequate level? I'm not so sure because these omega fatty acids can also, in high amounts, if they're really in high amounts, decrease the female hormone production. For female hormones, the better fats are cholesterol and saturated fats, not so much the mono or polyunsaturated fatty acids. Can Dr. Hertoghe please comment on using estrogen and progesterone in females that are 75 years or older and the risk of stroke? Is it safe to use or it should be avoided? So when there's stroke, and I suppose it's mostly ischemic stroke that is talked, that's due to a thrombosis, not blood supply, oral estrogens are contraindicated. Transdermal estradiol at low doses may be given on the condition testosterone is given, because testosterone is a blood fluidifier. And progesterone is antispasmodic for the arteries. Estrogens are also vasodilatating, so it would be good to give these women, but maybe not when they're in full problem, because there's a study in stroke patients that showed that women with high estrogen levels die earlier. So you should wait maybe a month or two, and then you give low dose of estradiol and progesterone in high amounts and enough testosterone, and then it would be safe. So estradiol in low amounts would be around transdermal 1 milligram per day or 0.75 milligram, etc. You can start earlier if that woman has a lot of female hormone deficiency, estrogen deficiency signs. Then I think it's safer to give the vasodilatating estradiol, but only transdermal in this case. Also in female with a hysterectomy, do you recommend both estrogen and progesterone in women who kept their ovaries but have hysterectomy? Yes, in hysterectomy, radically, yes, you need both estradiol and progesterone, not only estradiol. Why? Because estradiol, if it's alone, it will give breast enlargement and breast cyst if you don't give progesterone. Also, the mind will get too nervous if you give estradiol alone without the calming effect of progesterone for the mind, the brain, and the breast safety. You need to give both hormones, also in hysterectomy. Estrogen is linked to autoimmunity. We stopped oral contraception with ethinyl estradiol when patients have lupus, antiphospholipid syndrome. Indeed, the lupus is not due to the estrogens. It is due to a lack of adrenal hormones and some other conditions with a lack of nutrients that when they're lacking, you have more autoimmunity, like a lack of selenium or lack of vitamin D. So you basically, in patients with autoimmunity, like in lupus, you have to give them the treatments they need, like adrenal hormones, like cortisol and DHEA, and then they need also to have some female hormones in some cases, but you give lower dose of estradiol, and you only can give transdermal estradiol, not oral. The problem of the oral is that it accumulates in the liver, and then the liver starts making a lot of proteins. Sex hormone binding globulin, growth hormone binding globulin, cortisol binding globulin, etc., testosterone binding globulin. So basically, it makes that many hormone deficiencies are caused by excessive binding proteins in the blood of these hormones. So you lack those hormones. So Gira Ramin asked that if it's possible to prescribe a hormone treatment in a woman that has antecedents of breast cancer and ovarian cancer. Yes, you surely should. Also, a bit lower dose of estradiol, transdermal estradiol, and you give progesterone and you give testosterone. However, there's so much fear about the hormones that the patients themselves would refuse to take the hormones the first 2 years or 5 years. So you give them other treatments, give them a lot of carnitine, gives a lot of energy to cancer patients. And then you start giving the hormones when they suffer too much, or they're ready, open to give you explanation. I have women coming to my place to get female hormone treatment because they know I give female hormones when they have breast cancer. But I do give a little stage where I say, let's first check the other hormones. And then if you're not good enough, then I can give the hormones, but I make them also sign an informed consent form. In that case, that gives all the information, including the information of the studies showing that giving female hormones after breast cancer in usual rule will decrease breast cancer recurrence and will decrease the breast cancer mortality. Will we receive this PowerPoint presentation, anonymous entity? This is only PowerPoint presentation will be given to people who subscribe to the model. That's I'm giving a lot of information here. So you already have information, but for the handouts, you need to subscribe for the whole model. How can you lower SHBG if it is too high? If the SHBG hormone is too high, it can be simply because there's dehydration. The person doesn't drink enough water. So I always ask before a blood test that the patients drink half a liter of water before, in the 2 hours before, so there's no dehydration. And usually, if SHBG is too high, it's due either by an excess of estrogens or an excess of thyroid hormones, okay? But it also can be due high SHBG, which keep estrogens and other sex testosterone in blood too long. So there's a deficiency. It can also be caused because there's not enough male hormones, not enough testosterone, or not enough growth hormone. And not enough insulin, not enough cortisol, but basically growth hormone and mostly testosterone is too low in the case of high SHBG. Begin testosterone will lower the SHBG. Ali Ajam, many times progesterone replacement increases breast size, tenderness, and weight gain, even low dose. Yes, this happens, that progesterone normally decreases breast size. But if you give oral estrogen, oral estrogen in blood will become very high levels of estrone and low levels of estradiol because it goes to the liver. That's what happens. And when you give progesterone usually increases the conversion of estradiol, very potent estradiol, to the less potent estrone. Okay, but if there's very high estrone and low estradiol, the progesterone will do the opposite, and the very high levels of estradiol will be converted to no, the very high levels of estrogen will convert to estradiol, and so they get breast enlargement, etc. So you need to do a blood check before, because a woman can also naturally have high estrogen levels and low estradiol. So if you give progesterone to a woman who has naturally high estrogen levels, you will also create the same situation. So you need this happens that progesterone causes breast enlargement in women with high levels of estrogen, and this is often caused by oral estradiol. How can I see the attached files? Can we have slides? No, I answered this. And menopausal and taking BHRT progesterone on a daily basis without a break. My doctor prescribed for a year. If you take progesterone without a break, that won't harm you. If it's natural progesterone, bioidentical progesterone won't harm you. But taking estradiol without a break, that's not so recommended. So it's mostly estradiol that has to have a break of 5 days a month if you're on the menopause. What are the ranges for optimal estrogen, progesterone, and testosterone? I gave for estrogen and progesterone, I gave the ranges in the slides. So it's about 150 picograms per ml of estradiol in the 21st day of the menstrual cycle, 7 days before menstruation, in the mid-luteal phase. Progesterone, it's about 15 to 18 nanograms per ml at the same time. And testosterone, basically in picograms per ml, a little bit higher in luteal phase, but it should be around the 400 to 600 picograms per ml. Depends on the test you have, because some tests are more sensitive and measure more. I'm only on progesterone and no progesterone. With this cause any problem? I'm only on progesterone and no estrogen BHRT. Well, this woman who is only on progesterone and not taking estradiol, she will have estradiol deficiency signs. It can be fatigue, depression, droopy breast, dry mucosa. So it's not a balanced treatment, but it's not a dangerous treatment. It won't cause her breast cancer if it's bioidentical progesterone. And what differentiation do you recommend for female hair loss? Well, it was on the slide for female hair loss. And basically, you give the female hormones systemically, transdermal estradiol on the arms, for example, and then oral or vaginal progesterone. But you can also add a solution of female hormones, estradiol and progesterone, and even melatonin. And I have the formula in my Reversing Physical Aging book, because it's per 100 milliliter. I don't know 100% all the numbers, so you need to check that. If I understand correctly, a premenopausal woman who wants to become pregnant should only take progesterone for 7 days, 18 to the 17th day. No, if you have a difficulty as a premenopausal to become pregnant, you should make a check of all your hormones, because maybe you have several hormone deficiencies. But if you want to be pregnant, you can take only progesterone in second phase cycle if your only problem is premenstrual syndrome, and it will help you to be pregnant easier. But you have to start after the ovulation. Ovulation is around the 14th day of the menstrual cycle, so you have to start later with the progesterone. If you take estradiol, you can increase this before the ovulation an estradiol peak and then an LH peak. You can increase the estradiol peak and thus the LH peak and a better ovulation by giving estradiol before. But that can be started from 5th to 25th day of the cycle. But the progesterone will be started later than the 15th day. Otherwise, because if you once you take progesterone, it closes the cervix of the uterus, so there's no spermatozoid can come in. So that's why we start later with the progesterone, in order not to prevent spermatozoids to come in and fertilize an egg cell that has been arrived in the uterus. Is it possible to treat a 65-year-old patient with severe degenerative osteoarthritis with hormone replacement therapy? Of course, that's one of the treatments. If you have severe osteoarthritis, you need to have female hormones and you need thyroid hormones. That's the minimum hormones to give, and you should. It will relieve you a lot. Especially osteoarthritis. Of course, in osteoarthritis, there's also a lack of growth hormone and IGF-1. So you might take IGF-1 rather than growth hormone if you can have that. But basically, at least take a female hormone menopausal treatment with bioidentical hormones. That really help. And take some testosterone. It helps also a lot against osteoarthritis. Then here, a woman saying, my periods always start late since I started hormone replacement therapy, 35 years old, 6 months on transdermal estrogen, and always 10 days of progesterone from the 15th day. What is going wrong? your periods start late because you're maybe not taking enough estrogen. So when does periods come? Periods come when there's a drop of estrogens from very high to average or from average to low. So if you take estrogen from the 5th to 25th day of the cycle, and the progesterone 15 to 25th day, and you stop on the same days, 2 days later, you generally have menstruation. Maybe you're not doing it right. Maybe you're not stopping together with estrogen and progesterone. So you stop the same, 2 days later, you have menstruation. If not, if they come later, you're not taking enough female hormones. You need probably more estrogens. Please please repeat the name of the compounding pharmacy in Mexico. It's Bionuriso. B-I-O Nuriso, N-O-U-R-U-S-S-O. And they're, I think, located in Mexico City or just on the outside. And can women who react, you can always, if you want to have an address of one of the sponsors, you can always ask at our email address, office@hertoghe.eu. Can women who react negatively to progesterone, depression, cramps, fatigue, both with oral and vaginal intake, shorten the periods they take progesterone? You can shorten the period, but if you act negatively with depression and fatigue with progesterone, you probably have a lack of estrogens. So you probably need more estrogens. That's the solution. If I want an online, what can I do? So online, you can get all the information on our website, hertoghemedicalschool.eu, or go to the email office@hertoghe.eu. Terry, you mentioned testosterone, that's Phil Mycams. You mentioned at the end for the ladies, presume this is bilingual. Is it also transdermal? Please, do you recommend DHA sometimes in place? Cheers, Phil. Phil, I always like your comments and I always like you. So, yes, the testosterone we give to women, there are two ways. Either it's transdermal, that's in most of women. Either it's intramuscular, once a month. That's when a woman needs to be fantastic, you go up to to the intramuscular injection. But then there's a little risk of having higher amounts. So you have to block the conversion of testosterone to the masculinizing hormone, the dihydrotestosterone. But that will be well explained in the model. But it's great how a woman can react well on testosterone. It also makes female hormones safe because they have less risk of stroke and things like that. Please, do you recommend DHA sometimes? Always DHA in general in all women, because it's one of the hormones that decrease the most with age, and it's protective also against various forms of cancer. When a woman is on the contraceptive pill, how do we interpret correctly the lab test? Well, you cannot really interpret when a woman takes the birth control pill, one test is sky high with most pills, SHBG. That means that a lot of sex hormones are kept in blood because of that. And all the other hormones are suppressed. Estradiol is low or undetectable, and progesterone is also almost undetectable. LH and FSH are also down. So basically, it creates not a normal situation. And then I have here, can you provide a contact list of your currently practicing university graduates in each US states? We have a list of people that found, done different training programs, and I think you have them on the Hertoghe Medical School website. And if you don't find it there, it is there somewhere, but you can also get the information at office@hertoghe.eu. Now, how to prevent breakthrough vaginal bleeding? That's Zainal Daris who said how to prevent breakthrough vaginal bleeding in patients taking BHRT. So when they have a vaginal bleeding that is too early during the cycle, it is because there's a drop of estradiol. And that can be done because there's intensive exercise or if they have diarrhea. So if they have diarrhea or intensive exercise, and they consume too much estrogen, so there's a drop of estrogen, you need to supply an additional dose of estrogen. 0.5 milligram, 1 milligram more, depends on how intense the exercise is. And sometimes you need to do a trial and error. Also, if they have diarrhea, I had, for example, even a woman who had diarrhea during a pregnancy, and she had then bleeding. vaginal bleeding. She was losing the pregnancy because of a drop of estradiol. So in that case, we gave during a certain time estradiol additionally, and it saved her pregnancy. What about losing hair in postmenopausal period? That is typically, if it's in the middle of the head, mostly, that's a lack of estradiol. So you need to supply the female hormones. Here, Philip Kim says, my mother, 77, has dementia. She has moderately memory loss. Is it safe to give progesterone, estrogen, progesterone? Yes, it's safe to give, but you need to give a treatment that does not cause bleedings, vaginal bleeding. So it's from the 1st to 25th day of the month, you give an oral estradiol when there's dementia. Otherwise, the treatment is not good. And you give progesterone also. And then some testosterone, and she will do better. She will have a better memory. So studies have shown that in dementia, it decreases Alzheimer's dementia. And there's 8 times more Alzheimer's dementia in women at 80 years who have not taken female hormones. So imagine the consequences of not taking female hormones. So you can do it. She probably needs also some thyroid hormones as a minimum, additionally to that. Then Tedin X Bilic Stella, is there a doctor in Croatia who works according to your instructions? I think there is a person probably on our list because one came training here, but I don't remember the name. So yes, we should, considering that it's very difficult and expensive for us to come to Belgium. I think there's a Croatian doctor who knows more, but again, get to office@hertoghe.eu for the information. Stephen Jacobs, after getting hormones properly adjusted in accordance with your recommendation, what next step do you recommend in the quest to live longest possible? I have a module normally in September on longevity, hormones, nutritional therapies, psychology, lifestyle. I think you will like it. I will try to make it one of the best ever because I plan also to make a book on it. So basically, wait for that. But basically, you need to give all the treatments, correct all the hormone deficiencies, all the nutritional therapies, have a healthy lifestyle, and please take good care of yourself. Don't overwork all the time. I'm not the best person to say it, but I decided to change that recently, and I'm already seeing the first results. Then Tadin here again, talking about thyroid doctors, patients. So thyroid doctors, you have many websites with thyroid associations, thyroid patients. So those associated thyroid patients have a whole list of doctors that work with thyroid and that I think are valuable. Will you give hormone to women? Of course, our doctors that went on training know probably more, because you will see I'm making a model on thyroid therapy, and I can tell you, you have information you don't have in the books, but that's still taken out of the science partly, and a lot with personal experience, because you know, or you may not know, but I'm the 4th generation doctor working on thyroid therapy. So my great-grandfather published several books on thyroid therapy. My grandfather took over, my father took over. They were all fascinated about thyroid. So basically, it's really worth to have a physician going to that model on thyroid therapy. Anna Victor, will you give hormone to women with polymorphism, COMT, and GTSM? I think you can, indeed. They detoxify less if they have bad polymorphism genetically. I would certainly give female hormones, but if there's a little problem of having bad metabolites, with a lower dose of transdermal estradiol, like half dose. Anna Victor, how would you modulate it? Basically, I just answered lower dose of estradiol and always bioidentical hormones, and always give testosterone too. How to treat uterus myoma in reproductive women? Thank you. I explained this in the session on special cases and of the 3rd session, how to treat myoma. Basically, you might in this case give a synthetic derivative that is safe, like dydrogesterone, and I explained that you need to give longer time during the menstrual cycle, the progesterone. So earlier than the 15th day of the menstrual cycle, you need already to start with this dydrogesterone. If a female patient is on testosterone palette, does it make sense to give progesterone to balance the possible conversion? Yes, it does. Progesterone protects the woman against spasm of the coronary arteries, for example. So most women, when they have a heart attack, it's not by a block of the circulation. It's because there's a spasm of the coronary artery. And so the micronized progestin, the bioidentical progestin, protects against that. So Dr. Mohammad Dali, my wife, has leiomyosarcoma. That is, of course, already cancerous, if I understand. It's if it's a sarcoma. Of course, you need to take any cancer away, but if you're meaning actually that she has fibroids, that's the same answer as previously. You have to give longer the progesterone and higher dose of progesterone to get rid of that or to decrease it. Thank you for this incredibly informative webinar. I want to ask if a woman has hair around the nipples at age 25, 30, is it progesterone or higher testosterone levels? If there's body hair overgrowth in a woman, including on breast, for example, she can have several problems. It can be that she's not making enough female hormones, enough estrogen, or enough progesterone. It can be that she's making too much adrenal androgens, male hormones of the adrenal glands, because she's low in cortisol, and then she's overproducing in compensation too much adrenal androgens. Or it can be that the ovaries make too much testosterone, or she has a too quick conversion of dihydrotestosterone. So it's all treatable. That's the good news, but it should be treated not for health reasons, because having much male hormones makes of a woman a dominant character. So I don't want to decrease the male hormones. I want to increase the hormones she's missing to counterbalance it, and that will make. And maybe we have to give finasteride supplementary to decrease the conversion of testosterone dehydro. But finasteride is only safe when you give a little testosterone. So basically, it needs to be screened to give a good answer. But there's several options. And you have those options in my hormone handbook. In hormone handbook, that's the real guidebook for how to do hormone therapy. You have hirsutism, or how to treat that in women. What are the different possible causes and how to treat them? One quick question about a girl, 14 years, 3 years on growth hormone, has anxiety. Is this somehow correct? So it's a girl who's taking growth hormone and it's 14 years probably to grow. She's 3 years on growth hormone. She has anxiety. The problem of growth hormone is that if you give too much, you may have edema, and then it hurts and makes anxious. So exclude the fact that she's maybe overdosed. She will have a sort of painful joints and painful feet, especially. If it's not that, it could be that growth hormone increase the conversion of T4, pro-thyroid hormone, if you want, to the very active T3. And then she has moments of hypothyroidism, and that makes her more anxious. And that happens mostly in girls who are already a little adrenal deficient, because cortisol calms that down. So if you have too low cortisol, you have with growth hormone, when it's necessary in adults, there's a too quick conversion of T4 to T3. And so there's T3 hypothyroidism at moments. Given the intermittent need to increase immunity due to COVID-19, what do you recommend hormone levels be for men and women? Are most recommendation in addition to that recommended in this lecture? Basically, this lecture doesn't have so much hormone recommendations, but it's extremely important to have good mucosa. The first defense against COVID-19 infections, against the virus, is that it doesn't penetrate to the skin or to the mucosa of the lungs or the intestines. So basically, if you have more sex hormones, more estrogens, and more enough testosterone, the mucosa is thicker. It doesn't penetrate so easily. And so the first is to have all the hormones treated, especially sex hormones. There's studies showed that I think the mortality increased by 10 times in very testosterone deficient men. And that one of the reasons is they have a too thin mucosa. And then you should also have enough thyroid hormone, because thyroid hormones stimulate the immune system as a whole. So you have more immune cells. And more antibody production, especially antibody production is higher with thyroid hormones. And then, of course, you need to do nutritional therapies, but you have all that information in very much details and very practical details in the first module on immunity. And if you want some tips, we have this overview lecture that I did on that model in 2 hours that is accessible also freely. I think it's on the Hertoghe Medical School. You can get access on it. And maybe on our Facebook, there's a Facebook for the consultation. Breast density, B, RATS, D, the breasts are extremely dense, which lowers the sensitivity of mammography and hormone therapy. What to do? Do you really have breast density or do you have breast cysts? They're saying that, well, if there's breast cyst, you can decrease it with iodine locally and progesterone locally. I think it's probably excessive proliferation and there's our cysts between it. So I think you need to get a local treatment of progesterone and iodine. And if you get female hormones, you give low dose estradiol and higher dose progesterone. And then a last question, maybe from Catherine. I'm 38, estradiol dominant, progesterone deficient, but can't tolerate prometrium even at low dose or cream. Do you have an idea why? It makes me insomnia, anxious, like I drink coffee. I don't always have all the answers, but basically, if their progesterone are not tolerated, it could be because there's a estrogen deficiency, which should not be if you're estrogen dominant, or you have estrogen dominance at certain moments and not others, and then it's worth to stabilize the level of estradiol. It also could be that you're doing something wrong in the diet. It also could be you have high estrogen levels, and there's a remedy for everything. So basically, we need to do some more screening, but there are several options possible, and I talked about some of the options already earlier in answering the questions. And okay, so basically there, I think there's about 200 more questions. I think I cannot answer the other questions, but basically you've seen there's a lot of useful information. Many of your questions you have, almost all of your questions, the responses are in the model. So it's really great to see the models. It's very important that you also support our movement. It's cost enormous of work. Don't think I earn 1 penny with all the money you pay for the moment, because basically everything is invested in creating the movement. So it's really, so please support our movement. If you know doctors that will subscribe, do that, because the more we are, the more also we can help patients actually, and you really have a lot of valuable information. I really thank you of attending so long. I see there's still 270 attendees. They were up to almost 600-700 listening in direct. For some, it's a very late or very early hour. So basically, I'm very honored that you took the time to attend. And I hope to see you in the next seminar, maybe on Thursday. And there's also the one in end of February, but that's more for, there's the workshop. And there's the sort of practical question and answer session we can have. See you. Thank you. Have a nice evening. Thank you for attending.